Kind introduction, and thank you all for joining and inviting me to talk with you. A little bit of background, a little bit more background about me. I am a fairly new associate professor here at UCSD. I joined just over a year ago, so perfect timing with the global pandemic and such. But I was on faculty for about 6 years before that at the University of Wisconsin and developed a multidisciplinary working group for severe cases of pancreatitis due to a pre-existing interest I had in the surgical management of pancreatitis, which some people believe doesn't exist, but hopefully I'll convince you today that not only does it exist, but it's very important in a carefully selected subset of patients. I am hoping to, over time, and once the vaccine really gets going and COVID hopefully becomes a thing of the past, get much more established, a multidisciplinary group for assistance in taking care of these patients here at UCSD as well. I have adopted the previous name I had to what we will be developing is limping along a little bit here in the land of COVID as UCSD PANC, and PANC standing for Pancreatitis Acute Necrotizing Complex. And so this isn't really applied to the run-of-the-mill pancreatitis, but really severe sick people that will need multiple modalities of care potentially. So I have in quotations chair of the work group, which is currently very much a work in progress, although we are slowly coalescing and putting some future plans in place. So stay tuned, hopefully hear more about that in the future. Otherwise, I don't have anything to disclose except that I am a bit, and some people would say not a bit, but a total geek about this. So hopefully I'll elucidate a little bit why that is. And mostly it's because during my training, I kept running into pancreatitis and not having great solutions for it. And then as the literature will show, I kind of was available when this started happening and thought that there were some really nice options. And in my clinical practice, found a patient population that really were being, I thought, left in a lurch and needed a bit more attention. And so that's my background and my only disclosures about my geekiness for this. The objectives for us today then are to understand the natural history and prognosis of acute pancreatitis. We'll review some of the terminology and the relatively recent changes in clinical management. I need help from you guys. Maybe this isn't so novel anymore. I'm not sure if this is what the current teaching is. So I'm going to use this a little bit of research for myself. I'd love to hear feedback if this is helpful to you. I do geek out a little bit on the terminology review because I do think it's important that we have common words to talk about this, not only for research and outcomes purposes, but to know specifically what we're talking about in treating. So I do kind of make my residents be very specific about terminology, and I try to be specific as well. We'll also describe and apply the role of a multidisciplinary team approach in the care of severe acute pancreatitis. So just some basic stuff, and I'll try to go through this quickly because I'm sure none of this is new to you. Pancreatitis isn't super common, but with all cases, there are around 240,000 new cases per year. This is on the same scale as breast and prostate cancer. Of course, necrotizing cases are much more rare, with only about 5% of those, or 12,000 cases. However, it does lead to about $2 billion in costs to the healthcare system, so not insignificant there. Mortality has thankfully decreased significantly over time. So back in the early days, if you want to look at it that way of sort of modern medicine, mortality was at 65%. Even in the early 2000s, which is when I was sort of entering the medical practice, it was at 15%. Currently, however, we're at less than 5% and maybe even much better than that. And why is that? Well, because critical care really has matured during that time, and these patients really need advanced critical care management. We have also recognized the optimal or delayed timing of operative intervention. And we did go through a period of time where operative intervention was nearly abandoned. But as I, again, will try to convince you today, in the optimally selected patients, it can actually help quite a bit in the care of these patients. Things that have been recognized that in the first 3 to 4 weeks of the acute illness, multi-system organ failure is very common and very astute. Critical care is important to get the patient through this stage, but once they make it through, then it's not that the patient's out of the woods. At weeks 4 to 7, overwhelming sepsis can overwhelm and lead to a second spike in deaths of these patients. So over time, there's been a fair amount of literature that has described this. So reduction in mortality with delayed surgical therapy of severe pancreatitis in 2002, declining morbidity and mortality rates in the surgical management of pancreatic necrosis. then the step-up approach introduced by the Dutch researchers in 2010, and more recently introductions of endoscopic transgastric necrosectomy and the important role they can play in another specialized segment of patients. This is the patient that really hooked me. You can see this is from 2016. I was a junior faculty member, and this sort of made me push the issues that I was reading about and really apply the literature. So this was a patient back in Wisconsin, healthy, normal, 55-year-old female living her best up north rural life when she was stricken with gallstone pancreatitis. You can see there at the end of May that developed into necrotizing pancreatitis relatively quickly, and she got IR drained and then upsized. She had a number of complications and was in the hospital for a few months before surgery was even consulted. She did have portal vein thrombosis, some mesenteric venous thrombosis, which she had some clinical effects from. I eventually pushed and came up with a plan to do a video-assisted retroperitoneal debridement on 8/15 of that year. So she had been suffering for a few months, and she actually required, due to ongoing ascites, a TIPS procedure following that. So she is a bit of an extreme case. Here is some of her earlier case CTs. You can see the pancreatic head and neck here are poorly enhanced, if enhanced at all, and there's probably some poor enhancement here through the body and tail. She clearly has a distended gallbladder and gallstones. A bit later on, she ends up with walled-off fluid collection, walled-off necrosis. This is oftentimes referred to as a pseudocyst, but under 6 weeks, it really is not. And when we're talking about acute pancreatitis, using terms acute walled-off necrosis or acute walled-off fluid collection is much more accurate. After she had her IR drainage, you can see vast improvement of that walled-off collection. However, now you're seeing solid components that simply were never drainable by her IR drainage, with a very nice left-sided retroperitoneal drain. You can see it kind of coming out of her flank here. This image doesn't really show it, but even with this reduction in mass, she still had impingement on her portal vein and SMV. So this is when I finally got her to the operating room. So for a video-assisted retroperitoneal debridement, the nice thing about this technology is that we do not do a midline laparotomy, so we do not enter the peritoneal cavity. It's a relatively small subcostal flank incision. You can see me using ultrasound there, which we use to track the drain track and ultimately follow the drain where it enters the retroperitoneum, thereby keeping us out of the peritoneal cavity at all. And this is actually the very consolidated, thickened mass of pancreas that I pulled out of this patient. What happened immediately after me pulling this chunk of dead pancreas, dead tissue out, is a torrential amount of bleeding, probably because we tore her splenic vein. This is not ideal because we don't have direct vascular access. With some packing and holding pressure, we were able to stop the bleed, thankfully, and didn't have to do any additional procedures, and she recovered just fine. But this is my impetus to not wait too long for patients, because if you end up pulling out really solid, thick, hard tissue like this, your likelihood of causing collateral damage is much too great, and that puts the patients at risk and puts my heart health at risk as well. So backing up then to the etiology of acute pancreatitis, it's very important that we do not forget about this even when patients are significantly ill. So biliary and alcohol, of course, are the two top causes, but autoimmune pancreatitis does need to be considered if those two causes are not obvious. Medications are important to consider. Hyperlipidemia. I've actually seen a case of hypercalcemia due to parathyroid disease in a patient that actually went to have an acute parathyroidectomy. Oftentimes, something that I caution folks about is calling the disease idiopathic and not truly investigating what the cause of the pancreatitis is. And if so, everything has been eliminated and nothing else can be determined, I will still consider biliary etiology in those patients because even in the setting of a negative ultrasound, even negative MRI, up to 44% of patients can have biliary stones or sludge that can be the cause of their pancreatitis. And I've had 3 cases that I've taken gallbladders out after their pancreatitis has resolved and done an intraoperative cholangiogram to find common bile duct stones when they had been documented as having no biliary stones or sludge on imaging studies. So just something to keep in mind, that these patients do need to be followed long term and make sure that their underlying pathology is addressed. And oftentimes, if it's not completely clear in the sign of alcohol and we think it's alcohol, I'll often still, once they recover, try and get their gallbladders out. Scorpions are my favorite one to ask the medical students to catch them on, right? Because that's kind of fun. But I was just recently learned this: the scorpions that cause pancreatitis are apparently only from Trinidad. So unless you have a Trinidadian scorpion, probably not the cause of your pancreatitis. Just a bit of trivia there. A little bit of fun: the poor liver just doesn't want to be bothered by the gallbladder, who's so proud, who made stones, and then the poor gallbladder gets yelled at. He's just supposed to hold on to it, and there he is, sad. And we wonder why we get pancreatitis. He just wants a little bit of attention, so he spits the stones out. Poor gallbladder. Breaks my heart. All right, moving on then to the terminology I promised you. This is really based upon some folks getting together back in 1993 and then again in 2012 to really try to solidify what the names, so we can all, oh, Dr. Doucette's displaying his gallbladder friend. I think I might need one of those for my pancreas. We have little friends here in the office. So historic terms that I try to be very careful to stay away from, but I see not only in radiology reports, but in a number of medical records, are phlegmon, infected pseudocyst, persistent acute pancreatitis, hemorrhagic pancreatitis. These really are terms of the past and just aren't how things are classified either in a clinical or sort of research outcome methodology. And it's important when we have, especially multidisciplinary teams, we're all busy and running around, to use the proper terminology so that we can clearly determine what sort of treatment plans may be. So the term walled off pancreatic necrosis was introduced way back in 1993. And then in 2012, really differentiating, is this sterile or infected pancreatitis? Is it transient, or is it persistent pancreatitis that isn't going away instead of persistent acute, or intermittent? I've seen really trying to say what it is, and then delineate the spectrum of acute pancreatitis: severe, mild, etc. So this is the paper, if anyone's interested in looking it up, that really defines the Atlanta criteria, so you can reference that. It was in the journal Gut. They also outlined the diagnostic definition of pancreatitis of being 2 of 3 features: abdominal pain, 3 times the normal serum lipase, and then some sort of contrast enhanced imaging. And you need two of these out of the 3. Just be aware that at times patients may present late, particularly in a setting like ours. They're transferred in or are just late presenters. So we may not capture their elevated lipase. That does not negate that they could have pancreatitis. So an imaging study is really important. And CT is really quite useful, but it does need to be contrast enhanced so that you can see if there's areas of necrosis or not. The other thing the Atlanta classification outlined is 2 broad categories: interstitial edematous acute pancreatitis and necrotizing acute pancreatitis. And you can see the definitions there. There's 2 phases as well. There's an early phase in 1 to 2 weeks with a cytokine cascade and SIRS response, and then a later phase with persistent systemic symptoms, persistent organ failure, failure to thrive for the patients. Here are a few pictures of CT scans to give you a sense of acute necrotic collection. This was a 44-year-old man that was published in this article with acute necrotizing pancreatitis that really only show peripancreatic necrosis. So if you see here, and they have nice stars on it, the pancreas itself is very well enhanced in both of these, but all of the fluid and substances around the pancreas are inflamed. And so the pancreas itself is healthy. This is a 47-year-old woman with acute necrotizing pancreatitis involving the pancreatic parenchyma. And so you can see around the pancreas, all the tissues look pretty healthy, but here the head and the neck of the pancreas show no enhancement, while here in the body and tail, normal enhancement. So then 3 overall classifications: mild acute pancreatitis, which is for me very unexciting. So I put a big X in it. That's not something I'm particularly interested in. Those patients need good care, fluid hydration, and medical care, but isn't something that generally would raise the level of surgical involvement. Moderately severe acute pancreatitis or severe acute pancreatitis are much more interesting because the severity of illness is much worse. A lot of these patients will require ICU care, and they may be the ones that elevate to necrosis or needing surgical intervention. So severe acute pancreatitis, then 15 to 20% of pancreatitis, these patients do have the persistent organ failure. You have to really be on the lookout for these patients because they may look fine and be plugging along and seem like they're getting better, maybe just dragging their feet a little bit. And that can be a sign that they really are going to get sick on you and that there may be something inside brewing. Remember that this is all occurring in the retroperitoneum, so things can be subtly mulling along, and it can really be actually quite disastrous. So you do need to, once this develops into severe necrosis, really look at advanced organ support, including pulmonary, renal, cardiovascular, critical care support, looking at sepsis control, and I have prevention. I have more to say about that. I do not necessarily mean antibiotics here, but I do mean sepsis control and the ways of preventing it. You really want to optimize their nutrition, treat their pain, agitation, and delirium. And this is the point to get multidisciplinary care with gastroenterology, usually the interventional gastroenterology, interventional radiology, and surgery. This is a general overall roadmap, and we'll return to this in a few minutes, but which patients, again, are the most interesting to a multidisciplinary approach? Those that are most likely to require intervention and surgery. So those coming down here into the severe acute pancreatitis, and then specifically the ones that develop pancreatic necrosis or peripancreatic necrosis. Looking at the diagnosis that we touched on, very important again to determine etiology. You do want to pay attention to pain, nausea, vomiting, and fever. These patients are very likely to third space and become dehydrated. So checking, make sure their mucous membranes, if they're dry, they're getting appropriate resuscitation. Watching their abdominal exams, they're very likely to have reactive pleural effusions. And many times patients will actually have a prior history that they have chalked up to indigestion or biliary colic, but it's not infrequent that severe pancreatitis is preceded by lighter versions in the past. Again, amylase or lipase, typically lipase is measured 3 times normal. Amylase is going to return to normal much more quickly, so it's easier to miss a hyperamylasemia with pancreatitis. And then imaging, CT is usually the best. It's easiest to follow for most interventionalists and interventions involved. The other reason to sometimes avoid MRI in these patients is they're very uncomfortable. And so the imaging with MRI can oftentimes be quite poor. And if you get an abdominal MRI, you really need to get a full abdomen and pelvis to look for fluid collections, and that can take quite a while to get done if you're not doing it for just the purposes of looking at their biliary tree. And ultrasound is very helpful for biliary etiology, but oftentimes doesn't give you enough information for treatment of pancreatitis. I do leave a picture here of Cullen's sign because you don't see it very often, but that can also be a physical exam finding of severe pancreatitis. I'm going to go really quickly over this simply just to mention it. Ranson's criteria used to be something that we really drilled the surgical trainees for. It may be something you're familiar with. It's a little bit out of fashion for tracking, although it is still somewhat useful. It is good to have a general idea for. Apache score, SOFA, and Bulthauser scores are also useful in scoring pancreatitis. Most of these are more useful in a retrospective research manner, but do have some clinical ramifications in the ICU. And the Balthazar score is interesting because it is based upon imaging, CT imaging. So going back to our roadmap, again, focusing on the severe acute pancreatitis, these are patients who are in the ICU. They're requiring aggressive fluid resuscitation. Initially, they're usually NPO. They have an ileus. They're very sick. You do want to try to start enteral feeds as soon as possible. They may need an ERCP if you're worried about ongoing biliary obstruction. If you can't feed their enteral, their gut, you may need to consider TPN as only if necessary, and they may require repeat imaging to look for evolution of their disease process. Again, we do show an improving prognosis with necrotizing pancreatitis. However, there are two major changes that account for this, both the critical care management and the delayed operative intervention. And I think this is oftentimes some of the bias of why surgeons aren't interested, because operation really has gone out of favor early on, and it does need to happen a bit later. But my experience and my general practice is in being involved with them later, you need to be involved early. And so we are looking for that collegiality and cooperation with these severely sick patients. Things that we see typically within the first week is respiratory failure, of course, requiring ICU care. Greater than 7 days, you're more likely to see sepsis at that point for all of the other reasons in the ICU. Death is likely to occur actually later at 3 to 4 weeks from multi-system organ failure, and then even later than that from secondary sources of sepsis. So taking a moment about critical care, remember I told you guys I'm a bit geeky about this. Critical care, it truly is critical for these patients. They need very careful pulmonary management. They will third space like crazy. Their pulmonary pressures are going to go up because their compliance is not good. They'll often have large pleural effusions that may need drainage or consideration for drainage. And you have to be careful in your shock resuscitation of them. If you under resuscitate them, they're likely to end up with complications such as mesenteric ischemia, acute kidney injury or failure, multi-system organ failure. These patients may require dialysis. However, if you over-resuscitate them, which is probably more common in the past, abdominal compartment syndrome can become quite common. They have reperfusion injury. Over-resuscitation will drive the inflammatory cascade, making their SIRS response, coagulopathy, acidosis worse, of course, leading to multi-organ system failure and death. So you have to be very careful and pay very close attention to the physiologic data, their end organ hypoperfusion parameters, and monitor their intravascular volume as well as their cardiac function. All of the principles of ICU care and following that are super important, including following lactates and base deficits, CVP if appropriate, anything you can do to try to figure out what their intravascular volume is. It is in these patients that you do not want to do a surgical intervention if at all possible. You want to do everything in your power to prevent infection and sepsis. You want to try to provide them with nutrition if it is safe to do so, and then ICU principles of pain, agitation, and delirium management. I promised you a bit of time on nutrition. There is a great Cochrane database back from 2010 that looks at this, and there's a systematic review with 350 patients in 8 trials that looked at a difference between enteral and parenteral nutrition. And this is super cool because with enteral nutrition, you will have a decreased risk of death. And of course, anytime in medicine that we can prove decreased risk of death, it really is important to pay attention to. But you will also reduce organ failure, systemic infection. You'll actually reduce operative interventions, which although I like to operate is better for the patient, and we get them out of the hospital sooner. So why is this? It's maintaining the villus border within the gut mucosa. Eliminating translocation is probably the most likely mechanism that this helps folks. It also keeps them stronger and healthy to fight off and prevent infection. There is a historic idea to starve these patients to avoid pancreatic stimulation. That is not felt to be the case anymore. So even in folks, unless they're on multiple pressors, it is okay to start with oral feeds if they don't tolerate it because of bloating, nausea, vomiting. Sometimes they'll tolerate nasogastric feeds, nasojejunal feeds, and only if you prove you fail all of that should TPN be considered. Another study of 146 patients with moderate or severe acute pancreatitis that were randomized. Here they let people eat just when they felt hungry, no matter what their laboratory parameters look like. They just let the body sort of decide, versus conventional oral refeeding only once the doctor sort of felt their labs and clinical situation warranted it. And what they showed is when we let people self-regulate based upon how they felt, there was shorter length of hospitalizations and shorter durations of fasting. I'm going to take a quick break there and see if anyone has any questions or wants to interject anything before we move on to antibiotics and antimicrobials. Okay, I promise there's a question coming up shortly, so I'll make someone respond in a moment. So regarding prophylactic antimicrobials, and I'll preface this, oh, go ahead.
Sorry, there's in the chat box, there's a question. Is there a threshold for involving surgery, like certain imaging findings or something different?
Perfect. If you don't mind holding that, I'm going to try and hit some of the multidisciplinary stuff at the end. The easy answer is if you have a question or want us involved, please consult us. If it feels like something we really don't need or we can't help you, we'll tell you that. But if you have a question or if there's any level of necrosis, I think it's reasonable to have us give our opinion. Moving on to prophylactic antimicrobials. And I'm going to tell you, in talking to colleagues and folks around the country, there's a little bit of religion to this. Some people do believe it. Some people do not believe it. So I try to follow the literature. And the literature, this is a good sort of overall review of 11 randomized trial. And I think when you talk to most people, the idea is to avoid prophylactic antimicrobials. Let me see, I think there might be some questions here, if I can. Oh, it's not letting me. There we go. I was going to ask you guys this question, but I failed with my PowerPoint skills. So the bacteria that is traditionally in infected necrosis is E. coli, Pseudomonas, and anaerobic species, things that you would mostly expect in patients. What do you guys think develops in pancreatic necrosis when they've gotten a bunch of antibiotics? I think that I'm checking the chat. Fungus. Hold that thought. What about if I make you pick a bacteria? Yes. MRSA is the suggestion, and that's right. Anything that is resistant is going to develop. So you're more likely to get, oh golly, gram-positive organisms, and they're more likely to be drug resistant. And so you'll select out your easily treated bacteria, and you'll get folks with really highly resistant populations, which becomes really problematic in treating these folks and in giving them options for drainage later. So resistant bacterial infections, the prophylactic antimicrobial therapy increases the length of stay, increases the risk of operation or reoperation, increases readmission. And you can see fungus in these patients. However, prophylaxis with antifungals is still also not recommended. So looking at therapeutic antimicrobials, when should you use them? You should use them in the presence of clinical deterioration only, and probably not even based just upon the presence of air in the necrosis. So when you CT scan these people, classic teaching is if there's air, it must be infected. But if they're healthy and otherwise doing well clinically, you don't have to treat them with antibiotics because that isn't doing anything to make them systemically sick. You can consider FNA or biopsy or sticking a needle, but we worry about if it's not infected, of infecting it or contaminating it, if there's any translocation from the bowel. And then looking at carbapenems for first-line treatment for infected pancreatic necrosis. Again, this is quite debatable, and there's different ID departments will feel differently about this. There is a classic teaching that carbapenems do penetrate better into the pancreas. However, remember what you're trying to treat is pancreatic necrosum, by definition is dead. So most of that isn't getting any antibiotics to the area of dead tissue. So if the patient's not infected, or if the infection is kind of walled off and isn't making them clinically sick, but clinically they do look not great, what else could be causing them to look clinically cruddy? Is there another diagnosis other than infection that looks like sepsis?
Like from the cytokines and like SIRS response?
Exactly, so SIRS. So when those patients get, febrile, or they become even hypotensive or tachycardic, make sure that their intravascular volume is fine. You can culture them, make sure they don't have other sources of typical ICU infections if they're in the ICU or in the hospital. But don't forget that patients just sometimes have SIRS. And even if antibiotics are started overnight, reassess if you really think you need the antibiotics to treat the pancreatic necrosum, because many times you actually don't, and you can stop the antibiotics and just continue to resuscitate the patient, and you prevent the really resistant organisms from taking hold. So don't forget about SIRS. And then if we talk about operative intervention, why the heck are surgeons kind of not frightened, but not excited to go diving into pancreatitis bellies again? And I think this picture is the best picture I can find that really explains why. And I actually had the opportunity a few times during my training to go into bellies with really bad pancreatitis. And what you find is a literal bomb that has gone off. So the pancreas is inflamed. You can't tell what is pancreas. You can't really tell what is bowel. All of the fat is saponified. It's just a really, really big mess. And so there was a surgical dogma that if there is something dead in the body, it must be removed. And if it's infected, it must be drained. And in the retroperitoneum and with pancreatitis, that isn't necessarily true. And what history taught us is that if you dive into that, you can end up with recurrent debridements necessary, something that was even called pancreatic stomas, where this will just continue to drain over and over time, requiring multiple trips to the operating room. You can't tell what's alive. Bowel starts getting injured, and it ends up into an endless cycle of mess and yuck. So that all then led to decreasing mortality by saying, let's stay out of surgical, bellies and surgery with pancreatitis. And so in the 1980s and 90s, the idea of delayed operative intervention, and with decreasing incidence of operation, mortality started to come down. And this was again repeated, and we saw a decreasing mortality and length of stay with letting the body sort of wall this off and take a little bit of time to let them get over their systemic inflammatory response syndrome and their cytokine cascade from the severe pancreatitis. This is a really nice paper. You can see it's dated way back in 1997 that talked about delayed operative intervention. And this was kind of interesting because they looked at going in to operate at less than 72 hours versus late, which they define only as 12 days. And they had almost a reduction of half in mortality, and they found a decrease in intraoperative blood loss with waiting just 2 weeks to go in and do a necrosectomy. Now, this was not introducing any minimally invasive procedure. This was simply with open necrosectomies, very early jumping in versus waiting a while. And the idea here was that the OR doesn't actually interrupt the inflammatory response, that by draining or taking out dead pieces of pancreas, you're simply ramping up the inflammatory response more. And what you want to do is let the body wall things off and cool things down before you intervene in the dead parts. And later what was shown is that if you can actually get the patient out to 28 days or the 4-week mark, they probably do even better there once the SIRS has completely resolved. However, sometimes we can't do this, and we do have to look for other signs of surgical emergency that can develop in these patients. And so there may be exceptions to this mandate that require early focused operative intervention. And specifically, this is if the gallbladder has become necrotic, ischemic, and perforated, or if the same has happened to the colon. And when we take these patients, when that happens, obviously if there's a hole in another organ, we need to take care of that. But you really want to avoid the pancreas, and that can be really, really difficult to do because you see this gross stuff sitting there and you want to dig it out. But you want to still keep that necrosum walled off and deal with the pancreatitis separately for as much as possible. Same thing in abdominal compartment syndrome. If we open an abdomen for abdominal compartment, we'll try not to leave the pancreatitis completely alone. And I've had a couple cases that I've done this in. We've opened the belly, left the pancreatitis walled off, eventually closed the abdomen, and still gone to drain the walled off necrosis through a minimally invasive either interventional approach or an interventional approach culminating in a video-assisted laparoscopic approach. So currently we want to try to delay drainages and interventions beyond the 28-day period from disease onset. This will help us remove the pancreatic necrosum in one stage or with a minimally invasive stage and not enter the abdomen, and will allow us to avoid more open abdomen. The exception to this being if there's another reason to operate, including gallbladder or colonic necrosis. So the overall surgical principles here are avoid operating too early, inability to differentiate again between viable or non-viable or potentially viable tissues, which can be very difficult in these settings. Leading to inadequate debridement leads to persistent sepsis. So now you've only given them the bad effects of surgery while they still have to deal with their disease process. And one of the other things that can develop in these patients is disconnected pancreatic duct syndrome, which is basically a pancreatic fistula. So this can happen once we debride them either with IR or endoscopically or with a video-assisted approach. Oftentimes this can be taken care of, however, with prolonged drain treatment, and they will scar down and heal on their own. So the overall interventional options then to drain organized walled off necrosis past the early stage is to debride and drain via a percutaneous interventional approach, an open surgical approach, which sometimes is actually required based upon anatomic considerations, a laparoscopic surgical approach, which would include the video-assisted retroperitoneal drainage, endoscopic or GI approach. You can do any one of these alone or in combination, which is actually much more likely. So the percutaneous drain with a step-up process is the VARD and the Dutch approach, which we'll go over momentarily. Endoscopic transmural debridements, open necrosectomies, cystgastrostomies, sometimes need a completion distal pancreatectomy, maybe even splenectomy for disconnected duct. And there is some data on doing fistula jejunostomies, which I won't really cover here, but when I've seen them, they haven't worked out super well. The best choice will ultimately depend upon the patient's anatomy, where the necrosum is specifically located, the experience of your surgical team, your interventional radiologists, your interventional gastrologist, and your hospital's resources. Really, to take really good care of really sick pancreatitis patient, you need a coordinated effort with a multidisciplinary approach in order to coordinate percutaneous catheters with your surgical approach if that becomes necessary. And also to coordinate with your gastroenterologist to pick the best method to drain. There are intervention limitations. Percutaneous drainage does a great job of removing liquid components, but is really difficult to remove thick and solid necrosum. If it fails, patients may end up with a persistent draining fistula. And so if you're going to percutaneously drain patients, you must have another management strategy if that does not resolve. Endoscopic cystgastrostomy is a really great procedure that avoids surgical incisions either in the peritoneal cavity or even through the flank. However, there can be limitations to removing also very thick and solid necrosum. Oftentimes multiple procedures are required, sometimes even in the number of 4, 6, 8. There is some concern that when the stents are removed that there can be some recurrence, and there can be complications to prolonged indwelling stents. A VARD, or video-assisted retroperitoneal debridement, which we'll go over a little bit more in detail, isn't without its risks. It can result in hemorrhage and organ damage due to it being a semi-blind approach, although it is overall quite safe, and generally will take care of the vast majority of the necrosum with a very small incision. And you can also do an open drainage with a standard laparotomy. If done too early, it's much more likely to result in death. And you can have, again, if done early, worsening of your inflammatory response or other tissue damage. So the goal of any necrosectomy should be targeted removal of the necrosum in as minimally invasive a manner as possible that still allows broad drainage. So this is the Dutch study that was published in 2010, a step-up approach or open necrosectomy for necrotizing pancreatitis. So these were adult patients. This occurred in the Netherlands, and it was randomized after there was a decision for operating room. So these patients had all been observed and cared for 4 weeks. The two arms they were randomized to was necrosectomy, which was open with lavaging drains, or the step-up procedure, which at day 1, which again was 4 weeks in, a left-sided retroperitoneal drain was placed. If the fluid collection didn't completely resolve, just 72 hours later, that drain was increased. And if that didn't completely resolve the collection, in another 72 hours, a VARD was completed. And so this was all completed within about 1 week's time course. This was an intention to treat randomized study. There were 45 patients in the open arm, 43 patients in the step-up approach. You can see the numbers here. Both had follow-up care needed with either repeat operations or with additional drainage procedures, if not both. Interestingly, in the step-up approach, 45% or 19 needed a second drainage procedure, and 60 or 26 patients needed a necrosectomy. Of those, 24 got VARDs, 33% required additional surgery or other drains. Major complications or death was much less in the step-up approach than in the open procedure, as you can see here, and it was a cheaper approach by using the step-up process. So the take-home points from this study was that this study really changed the conversation about how to treat pancreatitis from a surgical perspective. It really hammered home the point that the necrosis is partially like an abscess, meaning it has a fluid component, but there's also a component of solid that may need to come out to make the patient better. It's overall less inflammatory than in open surgery. It requires commitment, however, from multiple services, including interventional radiology, surgery, and gastroenterology. You're more likely to maintain viable pancreatic tissue because you're only removing easily removed dead pancreas. And the VAR is an option for failed drains, but you need to think of it about it before you place those initial drains. Here's one of the initial papers about VARD, or a video-assisted retroperitoneal debridement. You can see it was published in 2007. They seem to have a patient that was much skinnier and less edematous than what I tend to see. So they have a very small incision, as you can see here. It is mostly an open procedure, but a camera is also inserted into the retroperitoneum, as you can see in the upper right corner here. That helps you visualize the dead tissue, and it can be removed with much larger instruments than you can do with a endoscopic approach. And again, if you have something this solid, that comes out. That was unusual. This is much more likely the piecemeal approach of this dead tissue that comes out. And every time I have someone new in the operating room for one of these procedures, there's this sort of sigh of, I get it. That's never coming out of a drain. That's just dead stuff. It's not going to come out. I like to say it's like having chunks of ice cream in a milkshake. Sorry if anyone's enjoying an after lunch treat, but you can't get those chunks of ice cream through the straw until they melt. And these guys aren't going to melt. So you got to take them out. Here are some pictures of that I have done clinically. It's a relatively small incision, and so this is the inflammatory cavity here. You can see things all look pretty dead and grungy. This is a suction irrigator, a long straw on a battery pack to suction fluid. Here again, you can see a lot of saponification. This is actually a bit of an open procedure. So again, you can see what a mess it is to determine what anything is. And then this is actually also an open necrosectomy that I did in a well-walled off field, but very similar. You can see a ring forceps and you pull off these large chunks of dead tissue that are never going to resolve. Again, another sort of typical patient that I have done in the past. You can see them in the operating room. They're bumped up. You can see they're still quite edematous, even though they're a ways out from their initial insult. This patient actually had 2 drains that were, this is actually post-surgical, but 2 drains going through the incision. The incision is actually relatively small, and the idea is to nuzzle into their retroperitoneum without ever entering the pancreatic cavity. And this patient was interesting. He actually required 2 VARDs. The first time I had a difficult time getting anything out, but by releasing that cavity, the second time in, I was able to get a ton more tissue out, and he got markedly better quite quickly after that. Again, just positioning in the operating room. I did want to touch on the endoscopic transgastric approach because I do think it's important, and Dr. Kwong and I work together quite frequently here. He's quite excellent at doing this, and I do think this is a very important approach, and I'm not advocating that all patients should have a VARD by any means, but due to anatomic position of the necrosum, patient considerations, it's good to have lots of tools in your toolbox. And so this is a study that kind of just looks at that, and I do think this is a really good approach for patients with clearly walled off necrosis, particularly if it's very central, if there's no access through the retroperitoneal window here, which I need to do a VARD, or if it's a smaller collection. I think it's very viable to do an endoscopic transgastric resection, but for very severe necrosis or necrosis particularly that's larger going down the gutters, the patient will then benefit from a VARD. And so going back to that question about when to consult us early. We are all happy to have conversations about these behind the scenes, and the earlier we can talk about it and discuss approaches, the more quickly we'll come to a cohesive decision in moving forward. And some patients require more than one approach. Upsizing of drains can result in clinical improvement in up to 75% of patients. And so I put a lot of work into patients that I never end up having to operate on, and that's okay. Again, it's about optimizing patient care, and we're happy to be involved in those discussions and decisions. And we can get resolution in up to half of those patients who get drains. Again, these are the severe patients with a lot of necrosis. But if they do need a surgery, we're happy to help expedite it. So how do we get to doing these? We just have to do it. We have to start seeing patients and talking about it and being collaborative in our approaches. Like I said, this is a bit of a work in progress, or actually a lot of work in progress, but we are working to build a multidisciplinary care coordination team. Eventually, I'd like to get it to, if you consult IR or GI or surgery, you'll actually get all 3 of us at once. So we'll all kind of take a look at the patient and determine what the best plan is based upon sometimes clinical resources, based upon what the patient's anatomy is, what the clinical course is, and then we'll work together to develop a follow-up plan after their intervention. We are working together, again, once COVID stops interrupting this so much, there is a pancreatitis multidisciplinary clinic every other Tuesday. In the ONC clinic is where it currently is, but this will allow us to see patients in collaboration once they're discharged between GI, IR, hopefully ID and myself or the EGS service. And we all talk via inbox or messaging or texting when appropriate, just to coordinate this care. Again, we're going to work on this, and hopefully you'll hear more about this in the future. And again, the things that we want to consult and coordinate on are nutrition, antibiotics, anticoagulation, determining the follow-up plan, communicate on an as-needed basis, monthly or bi-weekly conference to review active patients that we would hopefully get you all involved in the future when you have active patients. I do have a nurse working with me, Melissa Evans, who will help also coordinate this, who I have listed here with her email. So feel free to reach out to Melissa as well, and she can help coordinate all of our teams. A little bit of our aspirational goals here, and hopefully you'll set up some consulting orders. So if you can consult one team, you'll get all of us. This is something I did at the University of Wisconsin and hope to initiate here. And then one last plug for outpatient referrals. These are definitely patients that should be cared for in a quaternary care hospital that has access to all of these services. And so we should be encouraging transfers when our hospital has some capacity again, and helping optimize care, because oftentimes this is out of the realm of a community hospital, and the patients really do need subspecialized care. Take-home points for you all is to wait for the necrosis to mature. You really require about 4 weeks of drainage. Of course, there's always earlier reasons if they're septic or otherwise, but we do want to hold off on debridement for 4 weeks. So they may need a drain sooner, and that drain placement early is important. And so that's the importance of having surgery involved early. Antibiotics for clinical decompensation, just be mindful of if it's SIRS, and make sure that it's something that you need to treat and that it's not going to select for resistant bugs. Nutrition is key. You really want to do enteral nutrition whenever possible, and we're happy to be involved in the care of these patients. Anyone that you have a question about, we'd be happy to see. And these are just some other pictures. Can you guys tell that I really like pancreatitis?
Yes, we can.
I'm just opening up the chat again. Operative intervention rate, bleeding lower with delayed intervention. Yes, it is. Basically, how I like to think about this is if you have that walled off necrosis, and I'm almost amazed every time I operate on this, I can make a very small hole in this cavity that is developed, and it's a very robust inflammatory cavity, and I can clean that out. And everything's very walled off, and that actually keeps me away from intestines, vasculature, etc. So my personal bleeding rate and fistula rate, unless there was one pre-existing in the patient, is quite low, and I've tracked every single one of these patients. So I think this is a really nice, safe approach for them. The next question I see is best management approach for severe pancreatitis with associated ARDS, still delayed operation. It really is, because the ARDS is a secondary effect of the pancreatitis, and to operate on them acutely, they're going to require a laparotomy, because you don't have generally the retroperitoneal approach through the flank. So you're not going to stop that inflammatory drive. You need to get them through the inflammatory drives and ARDS, and then deal with the necrosis and walled off collections separately.
Thank you so much. That was great. Any other questions? Actually, I have just one question about, I know you mentioned abdominal compartment syndrome. So I'm assuming, I guess you would trend bladder pressures and whatnot to determine when to intervene. Is there anything like percutaneous drainage or something else that you can do to try and avoid the decompressive laparotomy?
Yeah, great question. And I would be happy to offer up, if you have a patient with severe necrotizing pancreatitis in your ICU, I would encourage you to consult the emergency general surgery service, because I think we can help you. All of us who staff the emergency general surgery service are the same as the trauma surgeons, and we're all double board certified in ICU care as well. So we understand the same ICU issues that you have and can really work together closely. Some of these patients, particularly if you're looking at abdominal compartment syndrome, are patients that we would be happy to bring onto the surgical ICU service as well. So we're happy to have those conversations with you. But to specifically answer your question, you know, more so than even following bladder pressure, the problem with that in these patients is they become so edematous that their bladder pressures aren't completely reliable because they're so, they have so much edema on them. So clinically in the ICU, I'm watching their urine output, which is hard in these patients because they oftentimes have renal failure, ATN. So I really will watch their ventilatory pressures and volumes. And so it's a tough decision. We don't want to open these bellies unless we're forced to. Some of the things that you can do to not open the belly is paralyze the patient. If they have a lot of ascites, sometimes you can draw the ascites off, but that's generally only a temporizing procedure because they'll fill that up again. So if you're in that situation, do please consult us. We'd be happy to be involved. And it's easier for us to make the determination to open the belly when we have the opportunity to kind of follow the patient for some time.
Thank you.
If I can, and I understand you all are busy. I'm also in our ICU this week, and so I know we're all busy and things are tight. I was just going to do a quick plug for, I've used the term emergency general surgery, and I'm not sure that is very well understood. So if anyone needs to cut off, please feel free to do so. Otherwise, let's give a little plug, if that's okay, Jenny, about what emergency general surgery is.
Yeah, of course.
Perfect. So I was brought as the medical director for emergency general surgery, which has sort of developed in surgery and trauma over the past 10 years across the country. And what happened was trauma surgeons were in the hospital all the time anyway, required by our level 1 certification to be here 24/7 for gunshot wounds, bad car wrecks, that sort of thing. We're taking care of ICU patients, but we're also taking care of any sick surgical consults that come through. And so a lot of our teams will work together very frequently. So necrotizing soft tissue infections, gallbladder disease, pancreatitis, clearly, appendicitis, perforated bowel obstruction, all of that sort of thing. And so I'm really working hard to develop our emergency general surgery protocols, our processes, our team, and, you know, want to be a great resource to you all for any sort of surgical question that you have. And the title for that is emergency general surgery. There are still the surgical subspecialty services, but we really can be and should be the go-to for any surgical emergency or consultation from inpatients at Hillcrest Hospital. And if anyone has any questions about that at any time, do feel free to give me a call, text me. If there's any way I can help you with that, please let us know, because we really want to be a resource to you and support you for any surgical questions that you have.
Great, thank you so much. Any other questions? All right, thanks, Dr. Liepert. This was great. Thanks for taking the time out of your day while you're on service to do this.
No worries. Thank you to you all, and thank you for all you're doing with the COVID. I'm sure you're all seeing even more of it than we are.
All right.
And Jenny, if you could send me the file, I'll put that on YouTube.
Yep, I'll send it to you right now. All right, thank you.
Thanks, great. If it's too big, I'll send you a Dropbox link.
Great.
Thanks, everybody.
Yes.
Thank you.